Welcome, everyone, to today's lecture on diagnosis and prevention of dental caries. We'll explore key topics including the acidogenic theory of caries development, methods for detection and diagnosis, preventive measures such as plaque control and toothbrushing, the role of nutrition and diet, fluoride's impact, fissure sealing, and personalized treatment planning for prevention. Let's dive in and equip ourselves with effective strategies to combat this prevalent oral health issue. Thank you. The acidogenic theory, proposed by W. D. Miller in 1890, provides a comprehensive explanation of how dental caries develop. Here's a breakdown of the key points outlined in the theory. Fermentation of carbohydrates. Microorganisms present in dental plaque on the tooth surface ferment carbohydrates from the diet. Rapid acid formation. The fermentation process leads to the rapid formation of acids. These acids cause a quick decrease in pH at the enamel surface. When the pH drops below a critical level, typically around pH 5.5, the enamel begins to dissolve. pH dynamics in plaque. When carbohydrates are not available, the pH of the plaque rises due to the outward diffusion and metabolism of acids. This rise in pH allows for the remineralization of enamel, which helps repair minor damage. Demineralization versus remineralization. Dental caries progress when demineralization, the process of minerals being stripped from the enamel, outweighs remineralization, the process of minerals being added back to the enamel. Maintaining a balance between these processes is crucial for dental health. Subsurface lesions. Early carious lesions in enamel are subsurface, meaning mineral loss occurs beneath an intact enamel surface. This differs from enamel erosion, where the damage is visible on the surface. Plaque composition and dynamics. Dental plaque, primarily composed of microorganisms, forms on tooth surfaces that are not properly cleaned. The composition of plaque can be influenced by diet, with diets high in sugar favoring the growth of acid-producing bacteria, such as mutans cocci. Stephan curve. Studies using pH electrodes, particularly by Robert Stephan, have revealed the dynamics of plaque pH following sugar consumption. This is represented by the Stephan curve, which shows that plaque pH drops quickly after sugar intake and takes about 40 minutes to return to baseline. Enamel demineralization occurs when the pH drops below 5.5. Overall, the acidogenic theory provides insights into the complex interactions between microorganisms, diet, plaque formation, and enamel demineralization, which are key factors in the development of dental caries. Clinical appearance of early lesions. Early lesions appear as white areas coinciding with plaque distribution. Common locations include gingival margins and interdental spaces. Histological and radiographic features. Histologically, early lesions appear subsurface, as seen in microradiographs. Microradiographs and histological sections depict subsurface body and surface zone of lesions. Cavity formation and progression. If caries progresses, the weakened surface layer crumbles, forming a cavity. Proteolytic enzymes from plaque organisms contribute to enamel and dentin breakdown. Progression through enamel and dentine. Traditional descriptions involve enamel caries progressing to the amelodentine junction, but cavitation can occur earlier or later in the process. Cavities can form at various stages, ranging from white spot enamel caries to significant dentine involvement. Remineralization of early lesions. Early lesions have the potential to remineralize during periods of plaque removal and neutralization. The opportunity for lesion healing is greater when plaque-covered teeth have shorter exposures to acid attacks and longer periods for remineralization. Preventive dentistry significance. The precavitation stage is crucial in preventive dentistry, as unbroken surface layers allow for satisfactory healing. Cavitated lesions can be arrested by effective plaque removal, but lost tissue cannot be replaced. Understanding the dynamics of dental caries, plaque formation, and pH fluctuations is vital for strategies in pediatric dentistry. Early detection and intervention during the precavitation stage play a key role in managing and preventing dental caries. Dental caries, white spot lesions, and saliva's role. White spot precavitation lesion. Visibility. The first visible stage of dental caries is the white spot precavitation lesion. It can appear within a few weeks under favorable conditions, but in the general population, It often takes 4 years for caries to progress from enamel to dentine at proximal sites. Role of saliva as a natural defense. Importance of saliva. Saliva is a crucial natural defense against dental caries. Rapid progression of caries can occur if salivary flow is impaired. Function: saliva. Physical removal of dietary substrates and acids produced by plaque. Buffering the pH in saliva and within plaque. Alkaline properties of fast-flowing saliva, pH 7.5 to 8.0. Essential role in raising the pH of dental plaque lowered by exposure to sugar and hydrates. Composition and role in remineralization. Saliva contains calcium and phosphate, crucial for teeth, composed largely of these minerals. Concentration of calcium, phosphate, and fluoride in saliva and plaque influences caries progression or regression. Fluoride aids the remineralization process and is considered crucial. Dietary stimulus for salivation. Presence of food, especially strong-tasting acid foods, is a powerful stimulus for salivation. Epidemiology of dental caries disease prevalence and variation. Global prevalence. Dental caries is highly prevalent globally but exhibits significant variation between countries, regions, social groups, and ethnicities. Epidemiological tasks. Epidemiology focuses on disease levels, variations, and changes over time. Tasks include understanding disease occurrence, monitoring changes, and explaining variations. UK National Surveys. National Statistics. The UK conducts comprehensive surveys every 10 years, starting from 1960, providing valuable national dental health data for adults and children. Advantages of UK surveys. National coverage with representative samples. Inclusion of clinical and sociological data for a holistic view. Well-described and standardized methods for meaningful longitudinal information. Children's data. Annual studies by the British Association for the Study of Community Dentistry and the UK National Health Service provide data on children at ages 5, 12, and 14. Methods to detect and diagnose of dental caries in primary teeth. Diagnosing caries, particularly occlusal caries where cavities may not be overtly visible, presents challenges for dental professionals. To overcome these challenges and ensure accurate diagnosis, various methods and combinations thereof have been proposed. Here's a breakdown of some commonly used diagnostic techniques. Visual inspection. Visual examination of tooth surfaces under good lighting conditions remains a fundamental method for caries detection. Dental professionals inspect dry tooth surfaces for any signs of demineralization, discoloration, or enamel defects. Probe/explorer. The use of a dental probe or explorer aids in removing debris and plaque, facilitating better visualization of tooth surfaces. It can help identify areas of softness or irregularities that may indicate caries. Bite-wing radiographs. Bite-wing radiographs are indispensable for detecting caries, cavities between teeth, and estimating the extent of the lesion. They provide valuable insight into areas not easily visible during visual inspection. Electronic methods. Various electronic devices, such as caries detection devices, use different techniques like electrical resistance or impedance to assess tooth integrity and detect carious lesions. These methods can enhance diagnostic accuracy, especially in early-stage caries detection. Fiberoptic transillumination. This technique involves shining a light through the tooth, which allows for visualization of internal tooth structures. It can aid in identifying subsurface lesions, including occlusal caries, that may not be visible with traditional methods. Laser diagnosis. Laser devices emit light at specific wavelengths to detect changes in tooth structure indicative of caries. Laser diagnosis offers precise detection and can differentiate between healthy and carious tissues with high accuracy. Key point: combining two or more diagnostic methods significantly enhances the accuracy and detection rates of caries. For example, integrating visual inspection with bite-wing radiographs or using electronic methods alongside fiberoptic transillumination can provide a comprehensive assessment of a patient's dental health. By leveraging multiple diagnostic tools, dental professionals can identify carious lesions at various stages of development and tailor treatment plans accordingly, leading to improved patient outcomes and long-term oral health. Equipment and examination. Basic equipment. Adequate lighting. Proper lighting ensures clear visibility during examination, aiding in the detection of carious lesions and other dental abnormalities. Compressed air. Air drying helps in removing moisture from the tooth surface, allowing for better visualization of lesions. Dental mirror. Mirrors enable the dental practitioner to view tooth surfaces that are not easily accessible, such as the lingual surfaces of anterior teeth. Blunt/ball-ended probe. A probe with a rounded tip is used to detect surface irregularities and soft spots indicative of carious lesions. Probe considerations. Avoid sharp probes. Sharp probes are contraindicated due to several reasons. Lack of diagnostic improvement. Sharp probes may not provide additional diagnostic information compared to blunt probes. Potential enamel matrix damage. Sharp probes can cause microtrauma to the enamel matrix, leading to potential enamel damage. Risk of bacterial transfer. Sharp probes pose a risk of transferring cariogenic bacteria from one tooth to another, potentially contributing to the spread of dental caries. Teeth preparation for examination. Drying. Drying the teeth is essential for identifying early lesions, as moisture can obscure visual examination finds. Flossing and temporary separation. Flossing and temporary separation aids allow for direct visualization of proximal areas, facilitating the detection of hidden carious lesions. Utilization of bite-wing radiographs. Essential for hidden caries. Bite-wing radiographs are indispensable for detecting hidden caries that may be visible clinically, especially in the interproximal areas. Benefits. Bite-wing radiographs provide valuable information for estimating lesion extent, monitoring lesion progression, and guiding treatment planning. Diagnosis considerations. Determining demineralization presence. The operator must the presence of demineralization and evaluate lesion depth and activity rate. Quantitative assessment methods. Techniques such as electrical conductance and laser fluorescence provide quantitative data that can aid in assessing lesion progression and determining the need for intervention. First visible sign, white spot lesions. Appearance. The first visible sign of dental caries is often the white spot lesion. Initially, it is observed when the tooth surface is dry because demineralized enamel becomes porous, creating a white appearance. As caries progresses, the lesion may be visible even when the tooth surface is wet. Challenges. Differential diagnosis. Other conditions such as enamel hypoplasia, fluorosis, and arrested hypermineralized carious lesions can mimic white spot lesions, posing challenges for accurate diagnosis. Determination of etiology. Factors such as the location and surface characteristics of the lesion are crucial for determining its etiology. Visual characteristics for diagnosis. Caries versus hypoplasia, fluorosis, etc. Caries tends to occur at predilection sites, emphasizing the importance of location in diagnosis. Active carious lesions typically appear as matte white, with a rough surface, while arrested lesions tend to be glossy with a smooth surface. Brown spot lesions. Similar diagnostic process. The diagnostic process applied to brown spot lesions is similar to that of white spot lesions. White spot lesion. Challenges in dentine caries detection. Detecting dentine caries, particularly when large cavities are not visibly apparent, presents several challenges. Here are the key issues and difficulties associated with identifying dentine caries. 1. Occlusal surfaces. No visible break. Dentine caries occlusal surfaces may not exhibit a visible break in the enamel surface, making them difficult to detect visually. Shadowing under enamel. Evidence of dentine caries on occlusal surfaces may manifest as shadowing under the enamel, which requires careful observation and interpretation. 2. Proximal lesions. Similar difficulties exist in detecting dentine caries in interproximal lesions, where cavities may not be visibly apparent from the surface. Limited access to proximal surfaces further complicates the detection process, requiring additional diagnostic aids for accurate assessment. 3. Need for diagnostic aids. Visual limitations. Thorough visual examinations alone may not be sufficient to detect all enamel and dentine carious lesions, especially when cavities are small or located in difficult-to-reach areas. Dependency on diagnostic aids. Dependence on diagnostic aids, such as radiographs, bite-wing radiographs, caries detection devices, e.g., laser fluorescence, and transillumination techniques, becomes essential for comprehensive caries detection and diagnosis. Detecting recurrent caries is crucial for maintaining optimal oral health and preserving tooth structure. Visual examination and radiographs remain primary methods for identifying these lesions. Here are the key considerations for detecting and managing recurrent caries. Characteristics of recurrent caries. Recurrent caries often appear at the gingival margins of Class II restorations, where plaque accumulation and bacterial activity are common. Over time, the appearance of the restoration may deteriorate, necessitating careful inspection under optimal lighting conditions to detect changes indicative of recurrent caries. Differentiating recurrent lesions. Distinguishing recurrent caries from stained margins on resin-based composite restorations is crucial. Stained margins may not necessarily indicate caries activity. Alternatives to whole restoration replacement, such as polishing or exploratory preparations adjacent to the lesion, may be preferable, especially if the carious lesion is localized. Key point: repair and refurbishing of lesions are preferred over whole restoration replacement whenever possible to preserve tooth structure. Accurate detection and differentiation of recurrent caries are essential for appropriate management. This approach ensures minimum intervention while effectively addressing caries activity, thereby maintaining optimal oral health. Commonly used diagnostic aids. Radiographs play a crucial role in caries diagnosis, offering valuable views for assessing dental health. Here's a breakdown of the different radiographic views, considerations, and frequency of examination. Radiographic views. Bite wings, prefer detecting both occlusal dentine and proximal enamel and dentine caries, offering a comprehensive view of the posterior teeth. Orthopantomograms, OPTs, highly accurate for occlusal dentine caries, but less effective for detecting proximal lesions due to superimposition. Bimolars, less useful due to structural overlap, their effectiveness in caries diagnosis. Periapicals, comparable to bite wings in accuracy, but provide less information per film, focusing on individual teeth rather than interproximal areas. Considerations for radiographs. Systematic viewing. Proper illumination and magnification are essential for a systematic review of radiographs, ensuring comprehensive assessment. Age consideration. Bite-wing radiographs should be considered for at-risk children aged 4 and above, with the decision based on caries risk assessment and balancing diagnostic benefits with radiation risks. Radiographic examination frequency. Caries-active children, radiographic examinations may be required every 6 months for children with active caries, facilitating early detection and intervention. Controlled caries, children with controlled caries in primary or mixed dentitions may require radiographic examinations every 12 to 18 months, providing regular monitoring without excessive radiation exposure. Bleeding papilla as an indicator. The presence of a bleeding papilla may suggest the presence of an proximal cavity, indicating the need for radiographs to assess the extent of the lesion accurately. Fiber optic transillumination, FOTI, is a diagnostic technique used in dentistry to identify carious lesions by passing light through the tooth structure. Here's how it works. Procedure. Light source placement. A small, 0.5 mm light source is placed in the embrasure, or contact area of teeth. Transillumination, light is transmitted through the tooth, illuminating its internal structures. Observation, the dentist or dental professional observes the transmitted light and evaluates the appearance of the tooth. Interpretation, dark shadows, carious lesions appear as dark shadows or area-reduced light transmission when observed against the transmitted light. These shadows indicate areas of demineralization or decay within the tooth structure. Location. The location and extent of the dark shadows can provide valuable information about the presence and severity of carious lesions, particularly in areas where cavities may be readily visible. Advantages of FOTI. Non-invasive. FOTI is a non-invasive diagnostic method that does not require the use of radiation or contrast agents, making it safe for patients. Early detection. FOTI can detect carious lesions in their early stages, allowing for prompt intervention and of measures to halt further progression. High sensitivity. FOTI is highly sensitive and can detect lesions that may not be visible on conventional radiographs or visual examination alone, especially in areas such as interproximal surfaces. Limitations. Operator skill. Interpretation of 4D images requires skill and experience on the part of the dentist or dental professional. Limited depth. 4D may have limited depth of penetration, making it less effective for detecting lesions in deeper layers of tooth structure. False positives. Some non-caries related conditions or defects may also appear as dark shadows on 4D images, leading to potential false positive results. Carious lesions appear as dark shadows. Temporary tooth separation involves the placement of orthodontic elastomeric separators between teeth to create space for various dental procedures. Here's how it works. Procedure. Placement of elastomeric separator. A small, elastic ring, called an elastomeric separator, is placed between two adjacent teeth using specialized dental instruments. Creating space, the elastomeric separator applies gentle pressure on the teeth, gradually creating a small gap or space between them. Allowing time for separation, the patient is instructed to wait for a specified period, usually 3 to 4 days, to allow the elastomeric separator to create sufficient space between the teeth. Removal of separator. After the designated time period, the patient returns to the dental office for the removal of the elastomeric separator. Purpose. Direct access for examination. Temporary tooth separation provides direct access to the interproximal areas of teeth, allowing for thorough examination and treatment, such as placement of dental restorations, removal of caries, or placement of orthodontic appliances. Facilitating procedures. By creating space between the teeth, temporary separation facilitates various dental procedures by improving visibility and access to the treatment. Benefits. Non-invasive. Elastomeric separators are minimally invasive and do not require anesthesia or drilling, making them well tolerated by patients. Efficient. Temporary tooth separation is a quick and efficient method for creating space between teeth, typically requiring only a few days of effective separation. Considerations. Discomfort. Patients may experience mild discomfort or pressure during the initial placement of the elastomeric separators and while waiting for the teeth to separate. Follow-up. Patients need to return to the dental office for the removal of the elastomeric separators and any subsequent dental treatment. A. Radiographic image showing radiolucency on distal of tooth number 15 and mesial of tooth number 16. B. An orthodontic separator was placed and left in place for 3 days. C. Clinical image of the teeth after separation. D. There was no evidence of cavitation on either surface. Laser fluorescence devices. Laser fluorescence devices are innovative tools used in dentistry for the assessment of tooth fluorescence, including the detection of bacterial byproducts associated with carious lesions. Here's an overview of how these devices work, their potential benefits, and considerations for their use. How laser fluorescence devices work. Laser fluorescence devices emit a specific wavelength of light onto the tooth surface. Fluorescent molecules within the tooth structure, including bacterial byproducts present in carious lesions, absorb and re-emit light at a different wavelength. The device measures the fluorescence emitted by the tooth and provides a quantitative assessment of its intensity, which correlates with the presence and severity of caries. Potential benefits. Early detection. Laser fluorescence devices can detect carious lesions in their early stages, often before they are visible on traditional radiographs or clinical examination. Standardized measures. These devices provide standardized, reproducible measures of fluorescence intensity, allowing for consistent diagnostic decisions and monitoring of caries progression over time. Non-invasive. Laser fluorescence assessments are non-invasive and painless, making them well tolerated by patients of all ages. Considerations. False readings. While laser fluorescence devices show promising results, false readings may occur due to factors such as staining, calculus deposits, or soft tissue hyperplasia. Careful consideration and interpretation of results are necessary to minimize the risk of diagnosis. Supplemental tool. Laser fluorescence devices should be used as a supplemental tool alongside traditional diagnostic methods, such as visual examination and radiographs, to enhance overall diagnostic accuracy. Clinical judgment. Clinical judgment and experience are essential when interpreting laser fluorescence and integrating them into the diagnostic process. Dentists should consider the patient's dental history, clinical findings, and risk factors for caries when making diagnostic and treatment decisions. An active cavitated vestibular lesion on the upper canine can be easily identified on the fluorescence image due to the bright red fluorescence. Electronic caries meters are valuable tools in dentistry used to aid in the diagnosis of occlusal carious lesions. Here's an overview of how they work, advancements in caries diagnosis, and considerations for their use. Electronic caries meters. Principle: electronic caries meters measure the decrease in the electrical resistance of carious lesions compared to sound tooth surfaces. Carious lesions have a higher moisture content and lower mineral content, leading to reduced electrical resistance. Accuracy: clinical trials have demonstrated that electronic caries meters can provide good accuracy in diagnosing carious lesions when used meticulously and in appropriate clinical conditions. Limitations: despite their effectiveness, electronic caries meters have limitations that must be considered. Readings can be confounded by factors such as hyperplasia, overgrowth of tissue, immature teeth with incomplete mineralization, and especially moisture in the oral cavity. Advancements in caries diagnosis. Enhanced sensitivity. Electronic caries meters offer enhanced sensitivity in detecting carious lesions, particularly in occlusal surfaces where visual inspection alone may be challenging. Objective measurements. These devices provide objective measurements of caries activity, aiding in planning and monitoring of lesion progression over time. Non-invasive. Electronic caries meters are non-invasive and painless, making them well tolerated by patients, including children and individuals with dental anxiety. Considerations for use. Clinical context. Electronic caries meters should be used in conjunction with other diagnostic methods, such as visual inspection and radiographs, to ensure comprehensive assessment and accurate diagnosis. Moisture control. Effective moisture control is essential for obtaining reliable results with electronic caries meters. Saliva or other moisture in the oral cavity can interfere with measurements and lead to inaccurate results. Clinical judgment. Clinical judgment and experience are critical when interpreting readings from electronic caries meters. Dentists should consider the patient's dental history, clinical findings, and risk factors for caries when making diagnostic and treatment decisions. Electronic caries meters for interpreting the readings. Value 1 to 20 indicates sound enamel. This range suggests that the tooth surface is free from caries and is considered healthy. Value 2, 21 to 9 enamel caries. Readings in this range indicate the presence of carious lesions in the enamel layer of the tooth. It suggests early-stage enamel decay that may still be reversible with appropriate preventive measures. Value 3, 91 to 99, signifies early dentin caries. Readings falling within this range indicate the presence of carious lesions that have progressed beyond the enamel and have reached the dentin layer of the tooth. Early intervention is crucial to prevent further decay and potential complications. Value 4, 100. A score of 100 is considered established dentin caries. This indicates advanced decay that reached the dentin layer and may require restorative treatment such as fillings or dental crowns to prevent further progression and restore tooth function. In summary, electronic caries meters are valuable tools for diagnosing occlusal carious lesions, offering enhanced sensitivity and objective measurements of caries activity. While they demonstrated good accuracy in clinical trials, careful consideration of their limitations and appropriate use in the clinical context is necessary to ensure reliable results. When used alongside traditional diagnostic methods and with meticulous attention to moisture control, electronic caries meters can contribute to improved caries diagnosis and treatment outcomes in dental practice. Greetings, everyone, and welcome to today's lecture on the prevention of dental diseases in pediatric patients. As dental professionals, it's paramount for us to understand the crucial strategies in safeguarding the oral health of our young patients. Today, we'll delve into 5 integral components of pediatric dental disease prevention that form the cornerstone of our approach. Parents counseling. We recognize the pivotal role parents play in shaping their child's oral hygiene habits and overall dental health. Effective communication and guidance to parents are fundamental in fostering good oral care practices at home. Dietary management. The foods and beverages children consume significantly impact their dental health. We'll explore strategies for promoting a balanced diet that supports optimal oral health while minimizing the risk of dental caries and other oral issues. Fluoride delivery. Fluoride remains one of the most effective tools in preventing tooth decay. We'll discuss the various methods of fluoride delivery, including topical applications and community water fluoridation, highlighting their importance in strengthening dental enamel and preventing cavities. Pit and fissure sealants. Sealants provide a protective barrier against dental decay by sealing off the vulnerable pits and fissures of the teeth. We'll examine the indications for sealant, application techniques, and their role in preventing caries, particularly in molars, among pediatric patients. Preventive resin restorations. Early intervention is key in halting the progression of dental caries. Preventive resin restorations offer a conservative approach to treating initial carious lesions, preserving tooth structure, and preventing further decay. Throughout this lecture, we'll explore each component in depth, discussing their significance in pediatric dental care and practical strategies for implementation. By understanding and incorporating these preventive measures into our clinical practice, we can empower our young patients to achieve lifelong oral health and well-being. Let's explore these essential components together. Plaque control. At the forefront of our preventive measures lies plaque control and effective toothbrushing. This pillar involves instigating behavioral changes, empowering children and their parents with the knowledge and skills necessary for maintaining optimal oral hygiene practices. Through proper brushing techniques and regular plaque control, we aim to mitigate the risk of dental diseases and promote long-term oral health. Diet. The significance of diet in dental health cannot be overstated. Recognizing the role of fermentable carbohydrates in the development of caries is paramount. By understanding how dietary choices impact oral health, we can educate our patients and their families on making informed decisions that support cavity prevention and overall well-being. Fluoride. Fluoride stands as a cornerstone in our arsenal against dental caries. Delivered in various forms, some of which require minimal patient action, fluoride plays a pivotal role in strengthening enamel and inhibiting the progression of tooth decay. While there's no magical solution that renders teeth completely resistant to decay, fluoride remains a crucial element in our preventive strategies. Fissure sealing. Fissure sealing emerges as a highly effective preventive measure, primarily targeting caries in pits and fissures. However, it's important to acknowledge its limitations, including cost considerations and the potential for sealant detachment over time. Despite these challenges, fissure sealing remains a valuable tool in our efforts to protect vulnerable tooth surfaces and minimize the risk of decay. As we delve deep into each of these pillars, we'll explore their significance in pediatric dental care and practical approaches for implementation. By embracing these key components, we can work towards creating a solid foundation for lifelong oral health and well-being in our young patients. Let's embark on this journey together as we unravel the key pillars of prevention in pediatric dentistry. Let's delve into why prevention forms the bedrock of dental care for children. Prevention versus cure. In the realm of dentistry, prevention reigns supreme. It's not merely a mantra, but a guiding principle that underpins all aspects of dental care, especially for children. By prioritizing preventive measures, we not only to avert dental diseases, but also to foster lifelong habits that promote oral health and well-being. Complexity of behavioral changes. Implementing preventive strategies in pediatric dentistry isn't without its challenges. It involves instigating behavioral changes, which can be inherently complex. From encouraging regular brushing habits to promoting healthy dietary choices, navigating these behavioral shifts requires a comprehensive approach tailored to each individual's needs. Tailored treatment strategies. Recognizing that every child is unique, we emphasize the importance of tailored, comprehensive treatment strategies in pediatric dental care. By taking into account factors such as oral health status, dietary habits, and socioeconomic background, we can provide personalized care that addresses the specific needs of each patient. Epidemiological distribution of dental caries. Understanding the epidemiological distribution of dental caries is key to our preventive effort. Dental caries distribution follows a bimodal pattern, with a significant portion of the disease concentrated in a minority of the child population. This necessitates a dual approach. Maintaining good dental health. Ensuring that children without decay maintain good oral health through regular preventive measures. Target high caries risk groups, directing resources towards high caries risk groups, including caries-prone individuals, children with early childhood caries, handicapped individuals, socially deprived populations, and ethnic minority groups often concentrated in urban areas. Low caries risk children. On the other end of the spectrum, low caries risk children who are caries-free or well-controlled, demonstrating good oral and dietary habits. These children are highly motivated and regular attendees at dental appointments, serving as exemplars of successful preventive care. By embracing these principles and understanding the epidemiological distribution of dental caries, adopt a targeted approach to prevention that maximizes impact and promotes optimal oral health for all children. Let's break down plaque control and toothbrushing for kids. Plaque control. Plaque disclosing agents. These are like magic potions that help us see where plaque is hiding. They come in tablets or solutions. But they need adult supervision because they stain your teeth temporarily. We use to track how well you're cleaning your teeth and figure out where you need to do better. Toothbrushing. How often? Brushing should be like your morning and bedtime rituals, something you do twice a day. Toothpaste. Use toothpaste with fluoride, which helps keep your teeth strong. There are lots of fun flavors and designs to choose from. Brush types. Whether you use a regular or electric toothbrush, both work well to clean your teeth. Supervision. If you're under 5, you'll need some grown-up help. And even after that, it's good to have someone watch until you're around 7 and can brush on your own. Fluoride toothpaste amount. For littles, a tiny smear is enough for kids under 3. For older kids, a pea-sized blob is perfect for those over 3. Rinsing technique. After brushing, it's best not to rinse right away. Instead, swish the toothpaste around in your mouth without water. This helps keep fluoride in your mouth longer, your teeth even stronger. Remember, keeping your teeth clean is like taking care of a secret treasure. You have to work to find and protect it. So, grab your toothbrush and let's set sail on our adventure to a sparkling smile. Caries prevention. Dental caries prevention logically involves removing plaque through effective toothbrushing. Important for controlling gingivitis and conveying fluoride to the tooth surface. Improved toothbrushing alone may not consistently result in caries reduction, but it plays a critical role in overall oral health. Flossing studies. Mixed results. Daily flossing in young children reduced caries in one study. Older children flossing their own teeth showed no preventive effect. Trials with intensive preventive advice and prophylaxis yielded significant caries reduction in one study but faced challenges in replication. Chlorhexidine rinsing. Prevents plaque growth when rinsed twice daily. Short-term use recommended due to intraoral side effects, changed taste, poor taste, tooth staining. Mainly advised to aid periodontal care. Let's simplify nutrition and diet tips for preventing cavities. Baby bottles. Stick to milk or water, skip sugary drinks. Toddler cups. Encourage cups with lids or straws to reduce spills. Healthier snacks. Choose snacks like cheese, fruit, veggies, or nuts instead of sugary treats. Be cautious with citrus fruits and peanuts due to risks of tooth erosion and choking. Better drinks. Look for drinks that don't harm teeth by making them too acidic. Eating habits. Meals start acid attacks on teeth, but saliva helps repair the j. Snacking too often can wear away enamel with little chance for repair. What science says. Research shows fluoride toothpaste can protect against sugar's harm. Studies found brushing twice daily with fluoride paste can offset up to 7 sugary snacks daily. Practical advice. Take good care of your teeth. It's okay to eat up to 5 meals a day. So, remember, drink smart, snack wisely, and take care of those pearly whites for a healthy smile. Here's straightforward practical diet advice. 1. Confectionery and treats. Save sweets and treats for after meals instead of snacking between meals. 2. Baby bottles. Stick to milk or water only in baby bottles. 3. Soft drinks. Preferably, offer soft drinks only with meals. If possible, use a straw when drinking. Avoid giving soft drinks before bedtime or during the night. By following these simple tips, you can help protect your child's teeth and promote good oral health. The mechanism of caries and the role of fluoride. Mechanism of caries. Caries formation. Evidence shows that cavities develop due to acidic plaque on tooth surfaces. Mineral diffusion. Acidic components seep into tooth mineral, causing calcium loss and dissolution of magnesium and carbonate. Spot lesion. The first sign of decay is a white spot on the tooth, indicating decalcification under the surface. Remineralization and fluoride. Rehardening. Tooth enamel can reharden with saliva exposure, but fluoride is crucial for this process. Fluoride's role. Fluoride in the mouth, especially at the enamel junction, is vital for preventing cavities. Topical action. Unlike previously thought, fluoride's effectiveness is mostly due to its topical application rather than systemic ingestion. Effective at low levels. Even small amounts of fluoride, as low as 0.10 ppm, can prevent enamel erosion effectively. Saliva and fluoride levels. Fluoride in saliva. The level of fluoride in saliva is essential for cavity prevention. Caries susceptible versus caries resistant. People prone to cavities usually have lower fluoride levels in their saliva, less than 0.02 ppm, while those resistant to cavities have higher levels, greater than 0.04 ppm. In short, cavities form due to acidic plaque attacking tooth mineral, but fluoride helps by promoting remineralization and preventing further damage, especially when present in saliva at adequate level. Fluoride products and methods for preventing cavities. Fluoride products. Available in different forms for both internal, systemic, and external, topical, use. Can be applied by professionals or at home. Fluoride methods for preventing cavities. Water fluoridation. Adding fluoride to community water supplies. Historically set at 1.0 ppm, parts per million. Shown to reduce cavities by 50% in 113 studies across 23 countries over 60 years. Cost-effective but faces some opposition. Fluoride tablets or drops taken orally. Varying effectiveness, 20% to 80%, and poor patient compliance, especially in high-risk groups. Can cause fluorosis if not used properly. Dosage depends on age and fluoride level in drinking water. Other systemic fluoride methods. Adding fluoride to salt, milk, or mineral water. Shown to reduce cavities by different percentages in various countries. Overall, fluoride is an effective way to prevent cavities, whether it's added to water, taken as supplements, or included in other products. It's important to follow recommended dosage and guidelines to maximize its benefits while minimizing risks. Fluoride levels and fluorosis risk. There's a concern about consuming too much fluoride, which can increase the risk of fluorosis, a condition that affects tooth enamel. Fluoride can be found in various sources like bottled water, baby formulas, chewing gum, and certain foods, adding to daily fluoride intake. People living in areas with fluoridated water might unknowingly consume more fluoride through processed or canned foods, known as the halo effect. Conclusion. Understanding how cavities form from acidic plaque and the importance of topical fluoride in preventing enamel damage highlights the need for targeted prevention. Different methods like fluoridation and supplements offer varying levels of effectiveness in reducing cavities. It's crucial to consider fluoride levels, compliance with recommended dosages, and potential hidden sources to develop a comprehensive preventive strategy. Fluoride-containing dental products, specifically toothpaste. Fluoride-containing toothpaste. Introduction. Since the 1970s, using toothpaste with fluoride has significantly reduced cavities worldwide. Types. Fluoride toothpaste can contain sodium fluoride, sodium monofluorophosphate, MFP, amine fluoride, or stannous fluoride, recently reintroduced with stabilization. Concentrations. Toothpaste for kids usually has less than or equal to 750 ppm fluoride, while adult versions typically have 1000 or 1450 ppm fluoride. Efficacy. Studies show that toothpaste with at least 1000 ppm fluoride is effective in preventing cavities. High concentration pastes. These are available with a prescription for people at high risk of cavities, but they need to be used cautiously in children to avoid fluoride toxicity. Toothbrushing with fluoridated toothpaste. Burt's View, 1998, describes using toothpaste fluoride while brushing as nearly ideal for public health. In simple terms, using toothpaste with fluoride is a great way to prevent cavities. Systematic reviews and guidelines for fluoride products. European Academy of Pediatric Dentistry, EAPD. Fluoridated toothpaste, EAPD measures its effectiveness in preventing cavities. They provide evidence-based statements and recommendations for children's use. Fluoride gel. Professional use, dentists apply high fluoride gels, 1.23%, using trays or brushes, reducing cavities by 26%. Safety, caution is crucial to prevent toxicity, especially in kids. Home use gels. Concentration, gels with 1,000 to 5,000 ppm fluoride are used at bedtime alongside brushing, reducing cavities by 36%. Fluoride mouth rinses. Types, daily, 0.05% sodium fluoride, and weekly, 0.2% sodium fluoride, rinses. Timing, at different times than brushing for better fluoride exposure, reducing cavities by 20 to 50%. Fluoride varnishes. Example, Durafat contains 5 Wt% fluoride, 600 ppm. Application, use sparingly due to potential toxicity, especially in kids. Cavities reduction, they decrease cavities by 50 to 70%, according to studies. In short, these fluoride products, like gels, rinses, and varnishes, have been shown to effectively reduce cavities. However, caution is needed to prevent fluoride toxicity, particularly in young children. Slow-release fluoride devices. Research objective, scientists aim to create devices inside the mouth that release fluoride steadily for at least a year. Fluoride glass devices, developed in Leeds, these devices release fluoride for over 2 years. Clinical trial results, studies showed a 67% increase in new cavities and a 76% reduction in new cavity spots in children at high risk of cavities. Promising application, these devices are ideal for groups prone to cavities, people who don't visit the dentist often, and those with health issues. Conclusion. With various fluoride dental products available, there are many options for preventing cavities. Fluoride toothpaste, gels, mouth rinses, varnishes, and new slow-release devices all help reduce cavities. It's important to choose products based on individual needs and risks, focusing on effectiveness while minimizing the risk of side effects, especially in vulnerable groups. Casein phosphopeptidomorphous calcium phosphate, CPPACP, and its remineralization mechanism. Remineralization mechanism. Dependency on saliva. Remineralization of teeth relies on calcium, Ca2+, and phosphate, PO4-3, ions from saliva. Of fluoride. Enhancement. Fluoride speeds up remineralization and encourages the formation of stronger fluorapatite. Limitation. Fluoride's effectiveness depends on the availability of calcium and phosphate ions in saliva. CPPACP technology. Definition. CPP stands for casein phosphopeptidomorphous calcium phosphate. Commercial products, available in topical creams, like tooth mousse, and chewing gum. Stabilization mechanism. CPPACP stabilizes calcium and phosphate ions using phosphorylated serine groups. Remineralization effect. It helps create concentrated solutions, promoting remineralization through concentration gradients. Oral retention, stays in the mouth for up to 3 hours, providing a continuous source of calcium and phosphate ions. Interaction with fluoride, enhances fluoride's effectiveness in the mouth. In summary, CPPAC technology helps remineralize teeth by stabilizing calcium and phosphate ions, which are essential for the process. It works alongside fluoride to promote stronger, healthier teeth. The application and recommendations for CPPACP. Preventive agent. It's recommended for children at risk of dental cavities as a preventive measure. White spot lesions. It's beneficial for individuals with early-stage cavities, white spot lesions, to aid in remineralization. Usage guidelines. It's suggested to use CPPACP after brushing, both at night and in the morning, especially for children at high risk of cavities. Fluoridated CPPACP cream. Products like Tooth Mousse Plus, containing fluoride, 900 ppm NaF, can enhance remediation effectiveness by around 25%. Generally, it's advised for children over 10 years old to reduce the risk of fluorosis from ingestion. In essence, CPPACP can be a valuable tool in preventing cavities and treating early-stage decay, especially when used alongside fluoride. It's important to follow guidelines for optimal effectiveness and safety. Fissure sealing technique and advances in sealant technology. Fissure sealing technique. Prophylaxis, before etching. It's not always needed, but advisable if there's a lot of plaque. Using a dry brush is better than paste to avoid retention in fissures. Isolate the tooth surface. This step is for a successful sealant application. Etching, applying 37% phosphoric acid for 20 to 30 seconds to prepare the tooth surface. Wash and dry. It's important to keep the tooth isolated and dry during this step. Apply resin. The resin is applied and then cured to harden it. Check adequacy. Make sure the sealant covers the fissures properly. These steps ensure that the sealant is applied effectively and provides the best protection against cavities. Sealant materials and application techniques. Sealant materials. Most effective material, BIS-GMA resin, is considered highly effective. Types: sealants come in autopolymerizing or photo-initiated resin forms, and they can be filled or unfilled. Preference: photo-initiations are preferred for their convenience, but unfilled materials have shown superior effectiveness in clinical trials. Operator teamwork. Sealant application, it requires effective teamwork between the operator and nurse. Isolation techniques. Cotton wool and suction. These are effective methods for isolating during sealant application. Rubber dam, while offering superior isolation, it may not always be practical to use. Glass ionomer sealants and their application technique. Glass ionomer sealants. Application technique, they are less sensitive than resin sealants during application. Retention issue, glass ionomer sealants generally have poor retention compared to resin sealants. Use cases. They can be used as temporary sealants during tooth eruption. Suitable for patients with anxiety or cooperation issues due to their simpler application. Effectiveness doubtful. Although they release fluoride, the clinical relevance of this feature remains uncertain. Advances in sealant technology. Bonding agents. Reduce contamination impact. They help mitigate the effects of slight salivary contamination on sealant retention. Prolonged procedure, however, using bonding agents can extend the procedure time, which increases the risk of contamination. Single-stage systems. Effectiveness, they work well on cut and smooth surfaces, but may not provide predictable results on occlusal surfaces. Sealing smooth approximal surfaces. Research, studies are being conducted to evaluate the effectiveness of conventional sealant resin in preventing the progression of caries on smooth approximal surfaces. Infiltrating resins. Development, these resins are designed to penetrate carious lesions rather than simply coating the surface. Success rates, reported success rates are around 80%, with only 20% of lesions progressing. Procedure, involves applying 15% hydrochloric acid followed by resin penetration, which requires the use of rubber dam and local anesthesia. What are preventive resin restorations? Preventive resin restorations, PRRs, are conservative restorations meant to treat minimal occlusal caries lesions. They aim to conserve tooth structure, enhance aesthetics, and improve the bond between the restoration and the tooth. Advantages. Preservation of tooth structure. PRRs limit preparation to carious pits and fissures, preserving healthy tooth structure. Aesthetics. They provide improved aesthetics compared to traditional restorations like amalgam. Restoration to tooth bond. PRRs offer a strong bond between the restoration and the tooth. Longevity elements. PRRs have shown good longevity and performance similar to amalgam restorations. Regular monitoring and maintenance are necessary to prevent potential loss over time. Indications and contraindications. PRRs are suitable when some fissure areas are carious, while others are not, with limited forces. They're contraindicated in cases where there's extensive caries or significant occlusal forces on the tooth. Technique. Preoperative evaluation and rubber dam isolation are crucial. Conservative preparation removes demineralized dentin and unsupported enamel. No pulpal protection usually needed. Restorative resin composite is used for deeper areas, while sealant or flowable composite is used for shallow preparations. Occlusal anatomy is sculpted before curing, and sealant is applied over the restoration. Final adjustments and surface sealing are done after curing, and occlusion are verified. In essence, PRRs offer a conservative approach to treating minimal occlusal caries lesions, preserving tooth structure while providing aesthetic and functional benefits. The technique for placing preventive resin restorations. Step-by-step technique. A. Preparation. The occlusal surfaces of the premolars show demineralization in deep fissures. A rubber dam is placed and inverted, with occlusion marked before its placement. B. Initial patient. A small round burr, no 1/8, is used in a high-speed handpiece to initiate preparation. C. Further preparation. Burrs of different sizes, 1/16, 1/8, and 1/4 round burrs, are used to open occlusal fissures. D. Alternative preparation. Acidotomy burrs, SS White, can also be used to open occlusal fissures. E. Completed preparations. Preparations are limited to access for removing carious tooth structure. Preparation is mostly confined to fissure enameloplasty. Penetration to dentin is minimal, occurring in limited locations. F. Adhesive system placement. After applying the adhesive system, restorative resin composite is syringed into deeper areas of the preparation. G. Developing occlusal anatomy. A hand instrument, like the PKT3, is used to develop occlusal anatomy in the final resin increment before curing. H. Final steps. The occlusal surface is re-etched, and occlusal sealant is placed over the resin composite and remaining pits and fissures. I. Completion. The occlusal preventive resin restorations are completed. This technique aims to remove carious tooth structure and restore the occlusal surfaces with resin composite, providing long-lasting protection against decay.